For joining us this afternoon. Welcome, students, faculty, staff, and community members. I'd like to start our event today by reading our Indigenous Land Acknowledgement Statement. The University of Wisconsin-Stevens Point exists upon land inhabited by the Indigenous people of this area, including the Ho-Chunk, Menominee, Ojibwe, Potawatomi, and many other nations and groups that predate colonial borders. We acknowledge that this colonization, that Native American people have been dispossessed of their lands and irreparably changed by the actions of individuals and institutions. We acknowledge our responsibility to understand and respond to those actions. In partnership with the Native American Center, we commit to working together to honor the past, be intentional in the present, and to build our future with truth. My name is Julia Fisher. I am the Assistant Dean of the School of Health Sciences and Wellness. Thank you for coming to share part of your day with us today. Our school at UWSP offers 8 undergraduate degree programs and 7 graduate degree programs, as well as several minors and certificates. So students, what that means for you is that there are over 50 full-time people working here to serve you and help you find your purpose and thrive in your future profession. Today's presentation will be informative and thought-provoking. As future health and wellness professionals, it's important that you understand health equity and the social and structural determinants of health. Health equity is achieved when everyone attains their full potential for health and well-being. To help you learn more about this topic, our Student Success Center's leaders have invited Paula Tran to campus. Can you please help me thank Sierra Schultz for organizing this event for all of you today? Paula serves as the State Health Officer and Administrator of the Division of Public Health at the Wisconsin Department of Health Services. In this role, she leads the vision for the statewide public health and health equity strategies. Paula is proud to be from Wisconsin and to have completed her education and training in her home state. Her public health experience has focused on exploring and strategizing ways to embed health equity and empowerment concepts into public health practice, policies, and scholarship. Paula, welcome to UWSP. Thank you for sharing this important information with us. Help me to welcome Paula.
Thanks so much, everyone, for joining today. I know not all of you had a choice. I know you're here because your instructors really thought that this might help you think about some of the ways you are shaping your future, right? So I'd love to just get to know you all a little bit. How many here are upperclassmen, juniors or seniors? Oh, pretty good number. So about the rest of you are not. How many of you are thinking about going into the clinical sciences? So you want to be a healthcare provider of some sort, a nurse, a doctor, a physical therapist. All right, good number of folks. All right. How about public health? Anyone exploring ideas around public health? A little bit. So that doesn't surprise me. When I was in undergrad, I went to UW-Madison. I have a bachelor's degree in biology, and I thought I was going to be a doctor. I went to school to become a doctor, and it was my junior year. I was doing all the things that you're supposed to do, as some of you juniors are probably feeling it, right? Doing all the volunteering, taking all the classes, doing the leadership development, and I was volunteering in our children's hospital in UW-Madison, and was interacting with patients and a couple of the trainees there. And this was a long time coming for me, but had a really challenging interaction with a patient who was really not being served well by the clinicians in the room. And being a part of that experience, this must be for drama. We'll hope that comes back. being a part of that experience really made me understand that clinical service delivery, at least day to day, was not going to be the way I wanted to improve the health and well-being of the people around me. Sierra, I think you might need to log in. We went to sleep up here. So I made the decision at that point in this room with this patient that that wasn't going to be my path forward. So, but I didn't have an alternative, right? I was knee deep in all the requirements to go to med school. I was in an MCAT class, and so I went home and I Googled health and social justice to try to figure out what my path might be, and that's how I learned about what public health was. Up popped the field of public health, up popped local health departments, and I started digging in, and I found an internship opportunity to work in a local health department, and that is how I learned about public health and started digging in with local health department leaders, public health nurses, policy folks, and learn the ins and outs of what it meant to be a public health professional. So as you are continue in your own coursework, would welcome ongoing dialogue with you. Often when I'm in conversations like this with students, I form a long-term conversation with them. Now many are in public health fields, so if any of that is interesting to you, please feel free to reach out to me after. Would love to talk with you about what you're thinking about and if public health would be of interest to you. So today I'm talking about health equity. Thank you for the instructor that handed out handouts. I would love to hear any of your questions afterwards. I want to leave enough time for you to ask questions. This is a pretty charged moment for this work, right? Lots of people, as people should, as leaders and politicians and leaders of institutions and governments should, care deeply about this work, and we have lots of different opinions about what it means to do this work. So now is an interesting moment to be in public health, and for someone who has studied equity and strategies to advance health equity, it's a very interesting time to lead. And for you all, I imagine it's an interesting time to think about what a career path is. So really welcome your questions after the conversation. So to sort of prod along in sort of marinating those questions, I'd love to hear what you all are thinking about and what how you explain health, right? You're in a College of Health Sciences. Your families are probably curious about what you do every day and what you're studying for. What is health? And how would you describe health to your grandma at Thanksgiving, or maybe to your 3-year-old cousin or a 3-year-old in your neighborhood? This is one of the 3-year-olds in my life right now. She's challenged by smiling in normal ways. So I'd like for you to just think about that and turn to your neighbor or the people around you and just, what is the first thing that comes to mind when you think about what is health? How would you describe it to a 3-year-old or your grandma at Thanksgiving? All right, I'm going to ask you to wrap that thought. I'm glad to hear people talking. And, you know, I remember when I was an undergrad, I wasn't always awake by this time of day. So I'm glad you're talking, and I even heard some laughter. What comes up for you? Just shout it out. What's something you heard in your conversation? Physical well-being. Thank you. What's another thing that came up? What are you telling grandma about what is health? Helping people feel good. Yeah. One more. Healthy food and play. Yeah. So when we think about health, lots of things come up, right? Including our physical being helping others, which is an interesting, more active sense of what health is, helping others feel good, and then food and play. So if that's health, what's health equity? I ask you to think about that again and just chat with your neighbor. So if those are the themes that came up for health, what is health equity? All right, I'll have you wrap that last thought. Same deal. What did you talk about? What's one thing that came up in your conversation? Opportunity, access, everyone. Awesome. These concepts feel so simple, right, to talk about. The deeper you get into your training, the more real these things are going to become. What is opportunity? What is access? What does it mean for everyone to have health? Become more and more complex the deeper you get into your healthcare or well-being sort of journeys, especially as you're trying to provide for others. So for me, I often start here, and if you've been to one of my conversations, you've heard this story before, so it's going to sound familiar. But it's the way I stay grounded and the thing that I keep coming back to, especially when things become really challenging and charged, about what does it mean to do health equity work and what does health equity mean to me? Because if you don't know what health equity means to you, it's going to really impact your ability to provide for others. If you don't know your skin in the game when it comes to equity, it becomes a very disingenuous practice to think about addressing equity if you're not holding yourself in the space of your care delivery or in your practice and whatever you decide to do. Because fundamentally, health equity is about our shared humanity, right? It's about when you see someone on the side of the highway in a blizzard and they're clearly having car trouble, it's about who stops, right, to help them. Right, it's about in a community when a tree falls down on a house, it's all the neighbors coming out to move that tree. Or when there's a community flooding and everyone's basements are flooded, neighbors and family members are coming to help. It's about sharing our opportunities because there is abundance in this world, right? It's about really thinking about making sure everyone has access, and indeed everyone, regardless and because of the fact that we are all human, right? And the more we can center ourselves in how we want to be treated and create policies and systems that support that, the better we all are, right? So this is my dad. I found a picture of him in a boat because his story for me that is most formative in my lifetime is one where he and my mom had just been arranged to be married. They were about 17 in Vietnam when that happened. They didn't know each other. It was a very traditional arranged marriage. And shortly after that, my dad decided he did not want to raise his future family in communist Vietnam. So he and my mom came up with a plan with my mom's brother and his cousin and a couple of other folks their age. They stole a boat and they escaped from Vietnam. This is late 1970s. And at the time, communist Vietnam was not amenable to their young people leaving so easily, right? Which is why they had to escape. When my grandparents found out about their plan, they did not love that idea. My grandpa told my dad, if I catch you trying to escape, I'm going to take care of you myself because that will be more humane than what will happen if you're caught. So my grandpa camped outside of my dad's bedroom window with a gun to fulfill that promise, or the door rather, and then my parents escaped through the window like good rebellious teenagers on a mission, and that is what they were on. They escaped, they left central Vietnam in the night, and the memories are pretty fragmented. We try to get our parents to talk about this today, and the memories are pretty choppy. We don't know how long they were at sea, but we know they landed in Hong Kong, who at the time was under British control, and they were welcoming to Southeast Asian evacuees and refugees. So they landed in Hong Kong and stayed in a refugee camp, and shortly after that had my oldest brother Hong, and then got connected to volunteer agencies, which are leaders around the world to help support resettlement of political refugees. So that is how they ended up in Green Bay. Green Bay has historically been known for its inclusion and welcoming and faith leaders that are so committed to ensuring that everyone, especially if they are fleeing from conflict, have a safe place to go and belong. So my family is in Wisconsin because of Catholic leaders who are deeply committed to inclusion and ensuring we had opportunity, access, and that we were a part of that definition of everyone, right? So we had no connections to Green Bay. If you're familiar with geography, Vietnam is a very tropical place. So we ended up in Green Bay and, learned a lot about what it meant to live here, what it meant to eat here, what it meant to grow here. And while the family that my parents escaped with moved to warmer climates, my dad and mom chose to stay in Wisconsin because of our very inclusive policies that supported public education for free for everyone, that had a leading edge insurance program, Medicaid, what we call Badger Care in Wisconsin, so that made sure we had access to health insurance and therefore health care, as well as a wide, rich range of programs that got us on our feet, right? My parents had to learn how to read and write English, so we were a part of a whole range of programs that stabilized our family, and then those policies allowed us pathways to thrive, right? Because we weren't starting in the same place as other families that grew up in the US, right? At no particular fault of our own, right? We didn't choose where we grew up. In fact, my dad chose to be in a place where there were programs and services and policies that allowed us not just to stabilize, but find pathways of thriving, have that opportunity of thriving. So those decisions, those choices, and that system of policy allowed us to, on paper, achieve equality, right? We all graduated from high school. We all have 4-year degrees. We are all, I think, contributing members of society, although, we debate that at Thanksgiving. So on paper, we really sort of closed the gaps in what it meant for us to achieve, right? If you look at all the indicators of high school graduation, of home ownership, et cetera, we ticked those boxes, which are really important. And over time, what I started to notice, this was when I first started giving these presentations, my family was also growing. This is my brother's Facebook post from 2012. Wifey had water break during the older kids' Christmas concert. Oh my goodness, it was madness, now at the hospital 5 weeks earlier than expected. When I went into grad school, I had this notion that because we made it, we worked hard, we leveraged all the opportunities available to us, and we did all the things that society asked us to do, including going to school, going to college, and contributing back. And then what I kept noticing in my family and my nieces and nephews is that even though my sisters and sisters-in-law did all the right things around prenatal care, they still had all these challenges, right? Our babies were born too early and too small, which in public health speak, that's a premature birth, right? Which sets you up for a trajectory over the life course. And at the same time, I was in grad school learning about equity and equality and the difference between what it means to just have sameness versus more equitable outcomes. And it's not enough just to make sure everyone has the same. It's also important that people are engaged in tailoring for what is the most responsive to their needs and context. So when I think about equity, it's not just about the policies or the outcomes, but really to create these conditions where you can be a full partner in defining what it means to you to be healthy and what it means to your family to be healthy, right? And for me, it's sort of thinking about sameness as everyone sort of gets one thing. Like if I gave you each a pair of shoes, that would be the same. But if they don't fit you, right, if they're not your size or they're not for the type of activities you engage in, not great to have flip-flops when you are a long-distance runner, right? You need to have a pair of shoes that fit what you need. And that to me is equity. It's not just about doling out the same thing to everyone, but making sure that what you need is reflected in the opportunities that you have and that you get a choice in the matter. And that has been something that I've studied over time, is that notion of choice or empowerment or agency over how things get decided for the things in your life also has an impact on equity. So this has been a quote that I come back to over and over again. I learned this from community organizers. And I learned this quote from community organizers at a time when I felt like I was always, I wanted to be the smartest person in the room. I thought I had the best ideas that we should implement. It was right after grad school. You get like that a little bit. And I was in my first job working with these really seasoned community organizers who were building coalitions with folks who had been incarcerated. And I came in and I wanted everyone to do all the things that I had learned in school, right? Because I was super excited about that. And I was checked in a really important way for my own learning. It wasn't just what I wanted to do. It wasn't just what I thought was the best, but I needed to really evolve my own thinking and my own perspective to doing with, which has been a really important lesson for me in sustainability, right? If we don't do with, if we don't engage in all the assets that are already there, we run the risk of creating change that may never take hold and sustain for the future, which is a really tough waste of resources. So this quote has been on my mind over and over again. We got to evolve from just helping communities to beat bad odds to working with and partnering with communities to actually change the odds. The odds themselves are a problem, right? It's not just the outcomes. So now digging in to more of the academic components. And for me, my own personal story brings the academic pieces to life. And the more scholarly pieces have created a pathway for me to have concrete solutions around the things that I have known to be true from my life experiences. So if I have one just sort of imparting thought for you all as you engage in what you want to do, is to ground your path in the things that really reflect who you are and the things that are most important to you and what you bring life experience to. So what is health? You all answered this question. You know this well. Your instructors are doing their job, right? Health is physical, social, and mental well-being, not just the absence of disease. And when we think about what shapes health in our communities, We know that these are the things that shape our opportunities, the conditions that shape our access to the things we need to be well, such as good food, safe places to play. But oddly enough, even though we are a state, a country that talks about health a lot, very few of our systems are actually designed to support good health for all of us. So I'm going to let that just sit for a minute. Very few systems in this country that sometimes appears to be obsessed with health are actually designed to create good health for all of us. I just want you to think about that, and if an example comes up for you, I want you to if you could just share it with someone next to you. Can you think of a system that's not designed to create good health for all of us? All right, I'll have you wrap that last thought. What's an example of a system that's just not designed to create health? What did you come up with? The cost of healthcare. Yeah. A very blatant example of a system that seems like it should be about health, but actually isn't designed to produce better health. What's another example? Yeah, yeah. Pharmaceutical companies, yeah. That the motivation seems like it should be to produce better health, but that isn't always what happens, yeah. What's one more example? Yeah, the way we make decisions about where grocery stores go does not produce health for all of us, absolutely. And coming back to this first example that was shared, right? Our health care system should be about producing good health, but in fact, it's a system that pays by volume and number of services. So the more services you use, the more money the system makes. But the services, by and large, are defined on sickness. So fundamentally, the way our healthcare system works is not about paying for good health, right, or incentivizing good health. Currently, and this is very general, we're incentivizing more and more services. So the sicker you are, the more dollars the system makes. And when we compare ourselves, our framework and our model in the United States to other developed and wealthy nations, our outcomes don't line up, right? We pay by far more than any other developed nation for a life expectancy or health outcomes that are not as good. So there's something, again, misaligned, right, with the way we incentivize our system that is not supporting health of our populations. And there's been lots of work to study this, right? So if the way we've designed our healthcare system doesn't support health, what does and what shapes health? This is the most updated framework from the UW Population Health Institute to really help us in the field think about all the things that shape health and how we're defining health. So up at the very top is our population health and well-being. These are things like length of life, the metric that was shown in the previous slide. The things that shape that are community conditions, things that you all called out, our health infrastructure, our physical environment, and social factors. We know drive and shape our ability to have access to opportunities that support health. And then there's this big bucket on the bottom here around societal rules that are driven by power. I'm going to define power in just a second. And as we think about, the ways that you will all be intersecting in health and well-being work, we'll invite you all to continue to think about power, your power, the systems of power that you engage in, and what that means for driving all these factors of health. So when we are wanting to produce better health outcomes for everyone, creating more opportunities and access, we really have to think about not just those outcomes related to length of life and quality of life, but we really also need to consider our community conditions. And more, this is more widely known as those social determinants of health or social and economic factors. So these are things like, again, housing and transportation, our civic and community resources, like our ability to vote, our ability to weigh in on what's happening in the community around us, our level of education, our income, employment, and all of those things are determined by societal rules. So then as we think, I want to offer a couple of definitions, and these are not necessarily the definitions that are widely used in every health department. These come from actually the Minnesota Department of Health from several years ago. And they've always helped me think about differences in language. And today, this would be an animated conversation, so I would welcome that any questions about that in particular. But so these are not necessarily the Wisconsin Department of Health Services definitions, but these definitions help me understand where we have possibility to intervene. So over the last decade, we've changed a lot of language. About 20 years ago, the predominantly way we talked about health equity work was around health disparities. And health disparities is defined as just differences in health outcomes by different groups. And that definition drove research, it drove allocations of budgets that focused in on these outcomes at the top, closing gaps in those outcomes, but didn't always focus in on these community conditions. So over time, we felt like we had to refine that definition to help us not just close gaps in outcomes, because as soon as we closed them and then took the resources away, but didn't change those conditions, those poor outcomes came back, right? So we had to be more specific in how we were thinking about health inequity in order to have longer term sustained change. And so, if health disparity was what we were doing about 10 years ago, this language of health inequity started to get more refined about 10 years ago. And an inequity is a disparity, so still a gap in an outcome, but it is defined as unfair or socially determined circumstances. So those societal rules that came down here actually determined the gaps in those particular outcomes. So not all health disparities are health inequities. Health disparities is an umbrella term, but some of those are health inequities, and those are where we can prevent or intervene in a way that can be more sustained over time. So an example of an inequity is that American Indians have higher rates of diabetes due to the disruption of their way of life and replacement of traditional foods with unhealthy commodity foods, right? So we're not just looking at diabetes in isolation, but we're looking at the drivers of why there are systemic and patterned outcomes in these particular populations. So that helps tell us a story about how to strategize on solutions, right? We're not just focused then on the diabetes gaps alone, we're also thinking about food systems and agency in defining food systems for very specific populations. And that created a whole field of equity work over the last decade. And that work has really focused in on those social determinants of health, focusing on a fair and just distribution of resources so that the outcomes, when they are changed, are also sustained over the long term by those community condition changes. And the big lesson there is that we not just need to change the outcomes themselves, but we need to change resource flows, right? And it's not always just about sameness. Again, not everyone getting the same pair of shoes. It's about everyone getting what they need in order to have those outcomes be comparable. So an equity strategy might mean each person in here gets a different thing in order to achieve the same outcome. That's a very tricky thing from a policy standpoint. See some people writing, I also welcome questions in between here too. So if you have something, a burning question that comes up, feel free to shoot a hand up. And I want to link this conversation to racism. It's now not always easy. It has never been easy to talk about racism, right? And today it continues to be challenging because it makes us uncomfortable, right? It makes us confront histories of decisions that have shaped different outcomes that are systemic for different people by race. This is deeply studied, and for all of us, or for those of you that are choosing a path in healthcare and wellness, it's something you will grapple with either directly or indirectly, right? If you are choosing a path to create wellness and health, you will experience differences in outcomes for populations you serve. And if you want to do something about it, an understanding about racism is going to be really important. And I'm not talking about necessarily interpersonal racism, although that makes a difference for health too, but on a system level, right? How our systems are designed to create different outcomes for different people in systematic ways, right? These are patterns that we can detect, and they're patterns that we can choose to do something about if we have, right, consensus and people coming together around that commitment. And these patterns show up in many, many different ways. But it's really around different policies that are excluding systematically, and that happening over and over again, and that getting under our skin, right? So one of the metaphors that has helped me think about this chronic toxic stress model, which is one of the ways we've shown that racism actually does things to our bodies, right? It's not just a thing that we feel, which is also in our bodies, but actually changes our chemical makeup through chronic stress models and chronic stress studies. So who here has driven in a blizzard? Some of us, right? Yeah, a lot of us. So chronic stress to me is like driving in a blizzard for a long time, and that in and of itself is stressful, right? If you've ever done that sort of white knuckle driving, you know, you can't see, you know you don't have full traction on the ground, other people are flying around you, right? It's an incredibly stressful experience. And when you get to your end destination safely, you feel that relief, right? Chronic toxic stress is when you don't stop driving, the blizzard doesn't stop, You are in a car that's not reliable with other drivers that are also not reliable, right? So all of the variables are amplified and it doesn't stop. And you can imagine what that does to our bodies over time, right? When our bodies have that much stress over time, that impacts our immune systems, that impacts our heart, right? Our heart rate. And that over time builds into our body's response and across generations, right? Which is why we don't want pregnant people to have so much stress, because the stress that they feel when they're pregnant will impact their future baby, right? So these chronic toxic stressors that we feel in our lifetimes also get passed on, like they would hair color or height. So that's why when we talk about the impacts of things like slavery being present today, that is a real biological observation. So we have a lot of opportunity, right? When we think about what we do about that. Sometimes I talk about this and it starts to feel really overwhelming, even for me, right? How do we do anything about that? But all along the life course and across communities, there are incredible intervention points, right? If you consider how many policies of exclusion have existed in the past, those are all also opportunities, right? So how do we systematically look at policies and programs so they're not systematically excluding anybody, right? It's sort of like a curb cut in the sidewalk. If we put curb cuts in, that's really helpful for folks with disabilities, but it's also helpful if you're pushing a grocery cart, if you're pushing a stroller, if you just are temporarily using a cane, right? So some policies can help everyone and not inadvertently exclude anyone, right? So how do we use that thinking in how we're making decisions around programs, policies, where to put grocery stores, where to put parks, right? Because currently those things are not random. And that's what I like to think about that we do in public health, right? Which is why it's sometimes so hard to explain what we do. Public health is what we do together, just like you said, to help others feel good, right? Public health is what we do as societies, governments, institutions, community organizations, clinical providers, what we do together to assure the people in our communities can be healthy. It takes all of us. We all have different roles, and one of the outcomes that we can think about targeting together is creating more places of opportunity for all people, more places of inclusion. So when I was in grad school, you couldn't graduate without having a slide with boxes and arrows. So this is my box and arrow slide. This is the Bay Area Regional Health Inequities Initiative work to really help us think about this from downstream to upstream factors. So this looks very similar to other frameworks that I showed, but what I think is really helpful about this is it also at the bottom here points to what we do. So along this spectrum here is the strategies that occur to really address downstream health outcomes, which is essentially mortality and the deepest morbidities, right? So down at the very end, when we're talking about life and death, that's our healthcare system, right? That is what we rely on our healthcare system, emergency departments, to help us avoid. As we go further and further upstream or to the left, that's where more and more health promotion and prevention ideas come into play, and these other intervention points. So further upstream from just the emergency department is how we think about communicable disease, right? How we stop the spread of COVID, for example, right? That is how, that is a strategy and a field of study that you could go to go further upstream. Further upstream than that is around behaviors, providing education, opportunities, and access around helping people understand the implications of smoking, nutrition, so that people can make the right choices for their bodies and for their families. Go further upstream than that, we need community conditions, policies, and systems that really support those opportunities. And that is the things like urban regional planning, right? In a health department, you might be convening coalitions to really think about food deserts or thinking about alcohol outlet density, right? The places where people live and work and play and how those places are designed to support health and well-being. And further upstream than that are places where we are making policy decisions. So at the business level, you might be in your HR office thinking about employee wellness and defining your employee wellness policy or insurance. At the government level, some of the work that I do at our state health department is defining policies that really can support local jurisdictions to support health and well-being in their areas. So for example, one of our requirements in our state is for every jurisdiction to have a community health improvement plan that is driven by a certain set of principles, but also by community voice. And at the state, we also have a plan. And we consider those plans to be documents that can shape policy to support health and well-being. And further upstream is around social inequities. And that is where our worldviews come into play in really concrete and important ways. So that is where our thoughts on class and wealth distribution or immigration status or gender or sexual orientation will play a role in how we define policy and what's possible for us to shape our decisions on access to opportunities and resources. And all of these blue buckets are skills that we use in those particular fields. So in risk behaviors, for example, you see individual health education and the ability to help consumers understand risks and important facts about nutrition and smoking come into play. In these areas, we see skills like community capacity building, community organizing, and being able to develop communities and leaders civically, and also policy strategy as important skills in these fields. And importantly, as we think about equity and closing gaps across this whole spectrum, we need a balanced approach. And historically, much of our approach has been down on the far right side. Again, that disparities framework, just closing gaps in health outcomes. And over the past 10 years, we've made a lot of progress to also close gaps in these living conditions, in these institutional inequities. And these are some of the things that at this moment are being widely contested, right, for how we do these things, especially in the public sector. Part of the reason that I think that they're widely contested is because we've been making good progress, right? And that has challenged the way we all think about resource allocation and what's possible, especially for folks in the public sector to engage in. But regardless of who is doing the work, regardless of whether or not you think it's important for the public sector to be doing this work, in order for all of us to achieve better health outcomes, somebody's got to do this work, right? So I referenced power in the county health rankings model. And I want to come back to the fact that power has been named over and over again by many large organizations that shape health and well-being. These are definitions by the World Health Organization. And they have named over and over again, especially over the last decade, that in order to make sustained changes on those social determinants of health or those community conditions, we really need to think about power and how resources are being allocated to really support those opportunities and ability to have access to things that make us healthy. I want to skip to this slide to help just identify some of the ways that power operates in access. right? And some of the ways that we can be thinking about building power or shifting power across how we can intervene on systems. So creating more access to opportunities, more access to decision-making spaces, and access to resources are some of the ways that we can think about embedding power strategies in our work. And power fundamentally is about how anybody, you, me, us as a group, can define the rules, right? Define the rules of how resources are being allocated. And when you don't have access to that decision making, that's called powerlessness. And we've spent over a decade studying powerlessness and its role related to equity. And what we know is individuals and communities that are experiencing the most powerlessness or the least access to defining how the world is working around them, even locally, right, are experiencing some of the worst health outcomes across populations. So, if that is true, that combination of powerlessness equals poorest health outcomes, a strategy we can think about as we're engaging in systems change is to embed approaches to power building in anything that we do. And to do that, it's really thinking about what is the change we're seeking to achieve, and the further we go upstream, the closer we get to addressing power. Really defining who is a part of the change. So really building capacity and decision-making power with those most impacted by those inequities are going to get us closer to building power in a more sustained way. And really thinking about how that change is happening. So not just, again, people in power doing things to people without power, but really thinking about embedding shared decision-making wherever possible. And the last set of slides that I'll leave with you is thinking about systems and where we can target systems. This is from the Water of Systems Change, just in case that feels interesting to you. And there's 6 general practices for really thinking about those systems changes. So if we think about embedding those 3 power building approaches along these systems changes, we can begin to think about how we help systems support health instead of what we discussed earlier, which is systems that are not really supporting health in pattern ways. So policies, practices, and resource flows are how rules are defined in government and institution policies. Practices, what we do in those institutions and how those either create health or make health more challenging. So these are like guidelines, procedures, things that shape habits of people within systems. And then where we put our money, right? Budgets are policy documents, right? And the things that we put in different budget lines tell a story about the outcomes we want to achieve. And then the last 3 components of systems changes are really thinking about relationships and connections, power dynamics within those systems, and the way we think about the world. And that's a lot of the social inequities that was on the far left side of the Bar-High model that I showed. So relationships and connections are about how we build together to support better collaboration and better flows of resources. Power dynamics is, again, thinking about those big systems interpersonally and how that is operating through each of us, right? Systems are made of people, and people are in relationship with each other. So this middle layer is about shifting interpersonal dynamics and connections across both organizations, but also people within systems. And then these mental models are really about the broad narratives and worldviews of how we think about each other and how we define what is possible. So the stories that are in the dominant media now about how we think about folks and whether or not we center humanness is really important towards shaping what we think about policies, right? And there's a whole body of work and evidence right now around narrative shift and how important the way we think about and talk about things actually shape the policies that are passed. So if you are a more communications-oriented person, that might be a pathway for how you think about your role in health and well-being. So with that, I'm going to just close out the slide part, but I think we have a couple minutes to take questions if anyone has any. Yeah. Sure. Yeah.
Seems like a lot of this work is challenging. So many layers, factors integrate. With community organizing, sometimes is that a challenge to truly like intrinsically motivate and engage the population you're trying to support?
Yeah, so the big question. The first is if you build it, they will come. I think we know the answer is if you build it without them, probably not, right? Which is a fundamental tenet of organizing. Nothing for us without us, right? Or any sort of remake of that sort of sentiment. And that sort of centered in that power building, right? If you're coming in to do something to us, it's probably not going to work really well. But if you want to work with us, let's figure out a way to make it happen. And we've seen and observed organizing work in some of the most disenfranchised communities all over the world, right? And when you think about the challenge of motivating anybody to do anything that they don't already see in their self-interest, that is huge, which is why most organizing is about figuring out what you care about and organizing around that. Go ahead. Yeah, so the question around what is my experience addressing rural health needs, and this is a huge challenge for all of us across the country. And in fact, most states and territories right now are writing grants around rural health transformation to address this very challenge. And I think similar to the first question is we can't do anything to communities without them, right? So the first thing that we're thinking about as we write this grant is how to be in community with folks and hear firsthand from rural leaders and rural residents what they're experiencing and what they want to do about it, right? And I think those are the only ways we're gonna, A, figure out a solution that is responsive and relevant, but also can be sustained beyond any kind of resources. So we do have pockets of bright spots of where this has been done well, but I think there's a huge challenge in folks that are not from and embedded in rural communities, not leading those efforts to really create solutions that make sense for those communities. Yeah, please. Yep. 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 Yeah. Yeah, chicken and egg, right? The challenges between grant dollars being about outcomes and counting things versus the long-term community capacity building needed. And the simple answer that's really challenging for all of us is our work to build capacity with anyone cannot be about one grant, right? Grants should help us do the important work, and we should always be building relationships with the people that we want to improve health with. And as grants come, to allow those grants to continue to support that work. And we have been doing a lot of work to help funders, government, myself included, and philanthropy and other grant-making organizations understand this, right? So shifting grants is one strategy so that grants can be more responsive to work on the ground, and that's why you're seeing more and more philanthropy groups and foundation move towards trust-based philanthropy. It's this recognition that you know best, not what our widgets are that we want to count, as well as us shifting our mindset for those of us that are working in community to not let grants drive the work, but to make grants supplement the work that we already think is important. Please, yeah. Yep. Yeah. Yeah. Yeah, so we've also been trying to do work with organizations that staff people, so research institutions, right, to actually allow for dollars that are not as restricted to support that ongoing relationship building. And we have seen models work. Institutions that support service, right, allow that service component to count that kind of relationship building as a part of that service. So we've also done work with academic institutions and research institutions to help redefine how some of the day-to-day is paid for, and then how the soft dollars or grant dollars then supplement in. But that's also that if we talk about systems change, right, you're talking about we need funders to change the way they fund. We need employing organizations that say they care about this, create space for staff to actually do that relationship and connection building work. And we can't rely just on soft or grant dollars alone to drive that work. If no one funds relationship building, we will continue to perpetuate this system that doesn't promote long-term capacity building for communities, right? So all of those things are opportunities for change. All right. Oh, go ahead. Yeah.
Thinking healthcare specifically, can you think of a really tangible or real example of how a healthcare organization might have used health equity in practice or change?
Yeah. Yeah. So Wood County is sitting right here in the room. So we've got a local health department here that has been staffing up community health workers and working with other community-based organizations to leverage a workforce. And community health workers are individuals that generally identify with or as the populations that a program or policy is trying to serve, and trying to help support a more comprehensive look at getting the needs met for those populations, whether it be in healthcare, right? So assuring that there is wraparound around any particular healthcare encounter to make sure social determinants of health needs are met as well as that particular healthcare encounter. So I would say community health workers are an example of an intervention that helps create voice for the community most impacted by staffing up with people that reflect that community, as well as not just think about the individual, maybe hypertension medication that was the focus of a healthcare appointment, but also all the other social determinants of health like employment, transportation, housing, making sure those things are also being met to really support that better health outcome. So that's one example. And Christy Aggie is here if you want to talk to her about how they're doing that in Wood County. Well, I want to be sensitive to, can we take more questions? Okay, one more question. Yeah. So to be clear, I wasn't a clinician. I was a student intern volunteering. But what, at the end of the day, more patient-centered care was what was lacking, right? We were supporting a young person, maybe 6 or 7, that had a Metaport receiving different medications for cancer. And I walked into a room, I got called into a room. There were a couple of interns, a couple of attendings, and a resident in the room. And this little girl was like hysterical. She was crying. No one could help meet her needs. And I got called in as a volunteer on the floor, a 21-year-old junior in college. And they said, help us calm her down. And so I went in, and I was jarred just to see this scene. And I just started talking to her. I said, hey, what's going on? And she said, no one will listen to me. I just want the medicine to make it numb. No one stopped to ask this little girl why she was crying or couldn't figure it out, because all she wanted was a topical anesthetic for her port before they poked her. And that to me was, well, there was a lot going on as a junior in college trying to, get ready for the MCATs and all the things. But I had been asking myself for a long time, right, how do I want to interact with health and well-being in the world? And that experience was, the final piece for me to see the way our healthcare system is today is not the way I want to interact with health and well-being. There's a lot that has changed over that period of time that has really focused on patient-centered outcomes and patient-centered care, and training clinicians and physicians to engage differently with patients. But that moment made me see the value in patient-centered care, as well as help me see other career paths. All right.
All right. Help me in thanking Paula for her presentation and being with us today. Thank you, Paula. All right, before I jump in just to a quick closing, I'm going to pull open just a quick eval, because we always want to know what you guys are thinking. You know that, right? So real quick, if you have a moment, you can do this now. Otherwise, I will send this out in an email following up our presentation today. There's also QR codes outside in the hallway as well that you can snap on your way out. So I'm Sierra Schultz. I'm the outreach specialist here at the School of Health Science and Wellness. I have met a few of you before. I've seen faces, but again, I'm located in the second floor of CPS, and oftentimes are out doing things like this, being able to plan opportunities for all of you to engage, whether it is on a topic like health equity, or if it's other opportunities to be able to engage in your community partners, learn about other organizations that are in your field. So I would like to just introduce you to the second portion of today's event. It will take place out by the concourse tables. I really encourage all of you to stick around and being able to engage with a lot of the community partners that have come today. This is a great opportunity to meet them in person, talk about what they do, talk about their organization, and maybe you can kind of figure out what it is that you like to do and how you can make some connections with them. So I would really quickly just like our table presenters to come on up to the front of the room. I did prep them for this, so yeah. Just so we could put some faces with names. So as Paula was talking about a lot of the different things related to how a community can be healthy, right, around equity, it's really about bringing everybody together and being able to make those connections for our future patients and our future clients and those that we'll be working with in healthcare. So it's important that we start to learn about what some of those community resources are. So I've invited with, oh, you guys look great. I just first want to introduce, and you can step forward as I introduce your organization and your name. So I have Myra Swiston here as a match specialist from Big Brothers Big Sisters of Central Wisconsin. We have, there there you are. We have a few people, but I think one is just up here right now from Portage County Health and Human Services, Division of Public Health. Briar is here. And so a lot of the work that Paula has referenced throughout her presentation relates directly back to the public health departments. And so Briar is the local one here in Portage County. We also have Marshville Clinic Health System here today. Suzette and Maria are here. Aspirus is with us today also, so Marissa is there on the end. We have ENT and Allergy Associates, so Blake Voss is an audiologist. He's with us today. We have Noble Community Clinics. We have Sarah and Madison who will meet with you. And as Paula was talking about community health worker, Madison is a community health worker. So if you're interested in learning more about that, you can definitely hit her up for questions. We also have Christy Eggy with us today. So she's at the Wood County Health Department. And she also works closely with Tammy Swenson, who is here. Do you want to give a wave, Tammy? And they'll be out front also answering any questions you have around some of the public health work that Christy is doing, but also around some of the work that many of our students, many of you, may be involved in working with Southwood County and our Legacy Foundation project. Okay, so before we all head out, again, the intention for this afternoon, the second portion is for you to really have this opportunity to meet with these great individuals, talk about their organizations, talk about what they do, gather some information from all of them, and please take a snack on your way out. So I think we've got some chips left, some cheese, and some water. So I'll let our partners head out first. Again, you can find them out at the concourse tables. So thank you all for coming today, and thank you, Paula.